Okay, before lunch, we need to review some structure we learned today about the knee, and I'm going to reduce some other structures for the afternoon. So, quadriceps tendons, patella, waiter's hand, femoral, pre-femoral fat. These all need to be clear in your imaging. If you email me or contact me with line, with a picture, and ask me what it is, Professor Wang, I will tell you, I may tell you, the tendon is not clear, the recess is not clear, the fat is not clear, the femur is not clear. I don't know what kind of imaging you sent to me. It's very common, really. So now you have been trained for more than one day. After these classes, when we communicate with imaging, please, skin, fat, superficial aponeurosis, tendon, fiber, interface between the fluid, fat, cortical line of the bone, all need to be perfect. Then we discuss what kind of patient you have. Okay, cool. For the people who have intratendinous lesions, for the people who have intratendinous lesions, you are looking for a probe about 12 to 15 megahertz. So people often ask me what kind of device I need. The question depends on what tissue you are looking for. Okay, you say, no, I want one device can see everything. Okay, one device to see everything depends on you need all the skill you need. Basically, there are 4 skill or 5 skill, basic skill, but I consider 7 basic skill, and you all learn the 7. Okay? Okay? There are another 4 advanced skill, but the 4 advanced skill basically designed for needle or inspiration procedure. Physical therapy do not use these skill very often. I might show you maybe next time if we have more class to you. Okay, right. 3 layer. If there is a intratendinous tear, medius latialis, the curve. If you want to study the morphology of the medialis, please use the curve. There is no way for ultrasound to measure the thickness, but you can measure the curvature of the medialis. Use free software like ImageJ, right? AutoCAD, but someone just remind me, AutoCAD is not free. Okay. But my student did not tell me this. Okay. Okay. The quadriceps tendons. Okay. The transverse view. This is a case of calcification. Quadriceps calcification. Okay. Tendon, hypoechoic, echoic shadow. So, study phase, milky stage, or milky phase. solid or milky? Milky, milky. Which one? Okay, I always ask questions to this table, right? It's not fair. So they start looking at the table. They don't want to look at me. Okay. There are a lot of young lady and beautiful lady over there. Okay. Milky stage or solid phase? Okay, good. Thank you very much. Okay. So, effusion, right? Effusion means poor proprioceptions. Thank you very much. So, I think I mentioned a mayor's wife. She had this kind of fluid in her knee, and she felt everything's okay, but the feeling from the knees slightly different. And my colleague took the fluid out, and she said she worked like normal again. Rupture, fracture, bursitis, waiter's hand. Okay, then you look at the joint restless effusion. I think the lady in this table, yes, has very mild, right? Very mild effusions. Very mild effusions. Okay, so if anyone show these symptoms, it's a very good opportunity to test your hand sensations. So if I found my patient have a fluid in the joint, suprapatellar recess, the fluid in the suprapatellar recess, I will use a manual technique to confirm this. Can you sit back? Backwards. Yeah. Thank you. Thank you. I will hold the medial side and the lateral side of the patella, and I will slightly press, and you feel the fluid come to your two fingers. Okay? And then when I was young, the feedback is very good, but I told Ajahn Vichai, the feeling is not good as before anymore. It's all right. So when I was a student, and there's a competition between physical therapists, we use this skill, and we tell our medical doctor friends what is the volume, 5, 10, 15, and they use needle to take it out, the measure. Who got the lottery? Yeah, the loser has to pay for the lunch. Yeah, so you can try, because there are some fluid in her right knee. Use this scale, right? And you can feel the fluid come to your two fingers. You press the fluid from the top. And the feeling are slightly different, slightly different. But if you can feel it, means the sensation from your hand are very, very good. Okay, you can try this. Okay, if there are more than 10, it's very easy. 15, too easy, no difficult at all. But 5, it's very challenging. So, luckily, I think the volume is about less than 10, more than 5. Yeah, so you can try this, but you got to ask her permissions, right? Cool. I think someone already tested. Cool. Okay. Thank you very much. Right. If there is a villi-like. We call this villi-like structure. It's chronic synovitis. Chronic synovitis. Yeah. And this thickened synovium may erode, cause bone erosion in the cartilage. So basically, thickened synovium make the osteoarthritis worse. Okay, so if you got a patient and like this one, it's okay. But a patient like this one, especially with the history of osteoarthritis, her situation is not easy to be reduced by or minimized by physical therapy, because the OA situation has been exist for a long time, and there are structural change in the synovium. The interact between the synovium membrane is very interesting. The tendon get impinged by bone. They are spur in the bone, and there are damage in tendon. If the synovium touch or contact the cartilage erosions, cartilage erodes, disappear. Make the cartilage thinner, and cause subconjugal cyst. Okay, so reduce the thickness of the synovium is very important. So my colleague used shortwave treatment. 2 months after, the thickness reduced. Okay. Okay, rhesus. If there are some fluid, you may observe from here or here. When you are looking at the suprapatellar rhesus, the probe is horizontal. Find the lateral border of the patella or medial border of the patella. Find the femur, horizontal, and find the retinaculum, rhesus. If there are some fluid that came out from this corner, especially the right corner, that is not good at all, because the patella is easily go left side, go lateral side, make more patella unstable. Okay. Good. Everyone is smiling. Good. So if you want to show me your pictures, you tell me, Professor Wang, this is a picture of my patients. What's wrong with the imaging? Okay, skin, fat, quadriceps tendons, cartilage. So this is not space, it's cartilage. Cartilage thickness represent the stage of osteoarthritis. If there is reduced in the cartilage in one aspect, medial aspect, lateral aspect, that means patella, the imbalance parallel patella. Okay, so for example, if the patella is moved laterally, the distance, for example, if this is the medial side, lateral side, the space, the cartilage thickness in the lateral side reduced in the case of patellar femoral syndrome. Okay, so what is your strategy for this case if there is narrowing in the cartilage thickness? Okay, young lady over there. The youngest lady in this table, which one? Okay, the students. Okay, you study in Taiwan, right? Good. You are going to answer all the questions in this afternoon. Okay, a case with patellar femoral syndrome. You show there is cartilage thickness. What are you going to do? What are you going to do? You are a physical therapist. Sorry? Ah, okay. So you are very young, I know. Sometimes, yeah, I use mobilization. Sometimes I also use lifting, patellar liftings. Yeah, okay, cool, very good. Okay, patellar femoral ligament. Patellar femoral ligament are also responsible for transmit the force from latialis and medialis. If the muscles are very weak, in the case of osteoarthritis, they are thickening, but hypoechoic, dark. This is very bright. But in the case of osteoarthritis, it's and become dark. Okay, if your patient have this kind of profile, they need exercise stabilization exercise training, knee stabilization exercise. So, okay, young lady, study in Taiwan. What are you going to do? What is the exercise for knee stability for people who had the osteoarthritis? Are you going to give them balance training? No. What exercise for the knee instability that you recommend? No. You look like innocent. I'm just a student. I know nothing. Why ask me? Okay. Keep smiling. I won't ask you now. Okay. But this is very important. Okay, remember that. If your old patient show thickened and swollen and hypoechoic patellar femoral ligament, they have problem of knee instability, at least patellar instability. Okay, we are going to look at the patellar tendon. Okay, but I think we are going to look at the patellar tendon after the lunch, but I'm going to show you some slides. Okay, patellar tendons. Two-layer structures, different to quadriceps. Okay, when you look at the patellar tendons, and the people show you these pictures, I will tell the people, okay, the knee is not fully bended. This is bridge-like patella. Bridge-like patella means bridge-like patella tendons. It means the patella tendon is not stretched. Okay, a friend of mine at the USC showed me, Professor Wang, we are doing some study on the patellar tendon. Can you confirm the image quality is good? And I say, okay, what is the patient position? The patient is sit with the tibia, an angle between tibia and femur, a 90-degree between tibia and the fibula. And I said, are you sure the knee is 90 degrees? I'm sure, the student said, because the patient is sitting. I said, no. Bridge-like, not fully stretched. The angle is not 90 degrees. Okay, for example, let's sit. Is it 90 degrees? No. That's the 90 degrees, right? The student told me he is sure because the subject is sitting. I'll say, okay, I'm going to talk to your supervisor. And 2 days after, you say, okay, I'm going to use goniometer to check everything is correct. I say, right, you learned something. Because images do not lie. Bridge line, 60, probably. Okay. Okay, there is a infrapatellar bursa here, small, no liquid, very few liquid, normal. HOFA pad. Yeah. If there are increased vascularization here, HOFA pad syndrome is not rare. Please be aware of this. It's not rare in athletes. Okay, cool. Tibia bone, cortex line. Vascularity, HOFA pad syndrome. My first case of HOFA pad syndrome is a case when I study in UK. Yeah. Because when I look at the ultrasound, when I look at my ultrasound image, and then my supervisor, he passed by and touched my shoulder, HOFA pad syndrome, and he went without saying anything. And I used the color, I used the power Doppler to check. And they say, yes, Professor Rolf, this is a case of HOFA pad syndrome. He looked at me and said, I told you is the most frequently used between my supervisor and me. When I discuss something with my supervisor, he said, I told you. So this time, when I become a professor, my student asked me questions. I said, I told you. It's a very brief, very powerful sentence. So the student become very concentrated and focused about what I said. Because next time, if they ask me a question again, I will say, I told you. Patella, transverse view. You are going to do that as well. So ask your patient to bend their knee with a degree of 90 and turn 90 degrees to look at the transverse view. Okay? Now we check this before. Okay. Then we are going to straight our knee to find the medial collateral ligament and the medial meniscus. Okay. The meniscus looks like this heart shape or triangle shape, whatever you want to describe. When I was a student, my teacher said this is a triangle shape. But anything about triangle shape, he says beginning, right? So I went to Japan, and the student told me, Professor Wang, this is not triangle in Japan, it's a heart shape. Because they like to do that, right? Yeah. Okay, good, whatever. Okay. Then the difficult part is when you find your meniscus, you need to trace 2 layers of medial collateral ligament. The deep medial collateral ligament, neck, to the medial meniscus. The superficial medial collateral pass and over the medial meniscus, then extend to the tibia. And if you move backwards, you will find the tendon of pes insurance. Okay? If you bend your knee, like the position for the quadriceps tendons, this is the, this is lateral meniscus, another. This is the position for the bending knee, okay. We are going to practice the straining, okay. Okay, this is a case of medial collateral ligament injury, hypoechoic, very dark, and a lot of color Doppler. But honestly, what's wrong with this imaging? If you were the author, basically we should use power Doppler, not color Doppler, right? The author used color Doppler. Must be a lot of bleeding in the wood. So it's an acute traumatic injury to the medial collateral ligament. The blood flow is very high, right? So the author used color Doppler. But for minor tear or minor injury with slow blood flow, basically we use power Doppler. The author for this imaging use color. I suggest, or I assume, this traumatic injury was feel a lot of blood. Okay, so basically we use power Doppler, not color Doppler. But in the case of acute, massive, traumatic injury, you can use color Doppler, yes. I just told them when I was young, I want to know the acute effect of the impact to the bone and to the tendon. So I talked to my colleague. I say, can I have some animals? But I don't want to write an IRB. And my colleague, he said, okay, the best resources he can get for me is pig. The pig waiting for become meal, yes. Yeah, okay. I went to the farm and used a little hammer, stimulated the tibia by different forces, then look at the ultrasound. Yes, I didn't create any image like this, but impact really caused the bone irregularity very quickly, instantly. Yeah. So a lady in this desk has recurrent injury, right? Knee injury. Or that table. A lady with atrophy, the medialis. Oh, a guy. Sorry. Sorry. It's my fault. Sorry, my fault. So there are some cortical irregularity. Okay. You can look at his knee. Okay, pes insurance. It's not difficult. Find the medial collateral ligament and move posteriorly, and you can get the pes insurance. There are two layer structures. The dark is medial collateral ligament, superficial layer, superficial layer. The superficial one is the tendon of passive inference. So, if you found the fluid above and behind, this is the passive inference tendinopathy. But some people suggest this is bursitis. But my supervisor, my boss, he did not agree there is a bursa. Yes. So I have been very cautious when I use bursitis. So I will tell you this is passive inference tendinopathy. Okay, because I am his student. Okay. Still, because I graduated from the chef for more than 20 years. I still keep contact with my supervisor. We wrote article more than 5, and he still is one of my best friend. Yeah, so I believe have a good relationship between supervisor is very important for academic career. Honestly, yeah. But he still told me, if I ask him question, he still told me, I told you. I published an article about the importance of the soleus rehabilitation in the case with artisanal repair. And I sent to him, I say, could you comment on the article? 3 words, I told you. You should have done that before, and you just finished right now, 20 years after you graduated from the university. What are you doing in these days? Yeah, very good academic researcher. Okay. On the day of his birthday, I sent him a message, happy birthday, and he replied me, where is your article? Okay, fluid, hypoechoical, dark tendon. So these days, you are very good. So your colleague show you, this is a tendon. I don't know what's wrong with the tendon. If the scale is correct, if the angle is correct, cortical irregularity, hypoechoic, fluid, and you will ask him, did you make any pictures with color? He said no, and you say, okay, you talk to me later when you get another pictures with color mode, right? And you talk very professional. And remind him, do not use color, use power mode, and he will be terrified by what you learned today. Okay, cool. So we finished the anterior part, and we carry out the medial part in the first part in this afternoon after the lunch. Okay? Any questions? Actually, there are two ways to measure the medial meniscus and the medial collateral ligament, right? But in order to save time, you are laughing. The Mahito staff are laughing. Hey, I know the secrets more than me, no, more than you. Okay, and because of the time, we only show one way. But if you have very good relationship with the Mahito staff, you can ask them to demonstrate another way. Okay. Thank you very much. Thank you. head of the LCL. No, stay. Yeah. Okay. Thank you. Yeah. Thank you. I think I'm going to. No, this one. I know you practice a lot, so sometimes we don't really need a lot of gel. Okay. Cool. Thank you. Thank you. Yeah, that's okay. Thank you. I know you can watch the TV behind me, so I'm going to review some works with you. Okay, in this view, I include the rhesus and the pre-patella fat. Oh, sorry, prefemoral fat in here. Okay. If you look at this view and you tell me you are looking at the quadriceps tendon, that's okay. But what's wrong with this imaging? Focus is not adjust. Okay. Okay, so you are going to see the imaging quality slightly changed, right? Right? In this imaging, you are easily to see the 3-layer structures, right? Very easy, 3 layers, right? If focus is wrong, it's not so clear. But if the focus is right, it's become more easier, right? So if you want to see the detail, you need to use correct focal zone. That would be very helpful. Okay, then full flexed, yeah, knee. Yeah, thank you. If I cannot reduce the height of the window, the best way for me is using the floating technique and using the tilting scale. Okay. Two-layer structure. Over the patella tendons. Superficial part, deep part, superficial part, deep part. Which one is more dense? Deep part. Yeah. Okay. So if you would like to discuss patellar tendons, if you would like to discuss patellar tendon with someone else, superior border, inferior border, okay, and no two-layer structure, I will say the image quality is not still good enough, but superficial border, inferior border, two-layer structures, right focus, depth, I probably cannot change with this device. Then I will say, okay, this image quality is much better. Okay? So, next, we need to do some distance calculations. I will do it again. Okay? Thank you. Thank you. The thickness of the tendon are very important when you check the morphology. If there is a focal thickening, we call spindle-like thickening. That is a sign of tendinosis, focal swelling. So you need to use your device to do some measurement later. Then, I promise Ajahn Preacher mentioned about some skill for the focus. Point of care ultrasound. Mean you need to use ultrasound in community care. Okay, just relax. Relax. Yeah. Oh, too much fat, sorry. Without compression make muscle thickness reduced. Floating scale is used again. Do not move. If you get a job from community care and you are hired to measure the muscle thickness in very weak people. Yes, they cannot get up from the bed. So you have to measure the muscle morphology when they supine on the bed. And you send an image to me. I will check gel between probe and skin. Means no compressions, no underestimations. Ooh, it's all right. Very sharp supraponeurosis. I don't really care about the fat because the fat is usually very bright because that's the sign of long-term disuse atrophy. Yeah. Very bright, deep aponeurosis. And that is, I will take the measure, the distance from here, and average it. This is the muscle thickness of the rectus femoris. And this is the muscle thickness of the intermediaris. Yes, thank you very much. Okay. And thank you. Again, gel, skin, fat, latialis, intermediaris. Okay? Gel, floating scale. Okay, you don't need your participant or subject get up from the bed. If your boss or your teacher asks you, they always ask, so don't worry, they will. To do the morphology evaluations. So, plus the image I just showed you, you need to complete another imaging of pennation angles of latialis. You can pick out 3 in the middle. They are 1, 2, 3, yeah, in the middle. So you can extend the line. Maybe the line may out of range in the window, but it's already, it is accepted in the research. Then you can pick out 3 and average them and report that is the pennation angle in the latialis. Okay. Subject does not need to get up. They are so weak. If you go to their house, say, I'm a student or I'm a teacher from blah, 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 and I'm very interested in the blah, 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 and your family has blah, 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 blah. Now I'm going to measure your muscle strength, blah, 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 blah. No, they don't listen to you. They don't want, they don't get up for you, just for your stupid research. That's the common phenomenon in Taiwan. So we have to measure the muscle morphology in very weak people. That's how we do it. Okay? Point of care, you go to their house. They go to the place where they live. You go to the place where the caregiver give the care, measure the muscle morphology. Okay? Then, okay, thank you. Use the palpation, find the medial collateral ligament. put the probe above. This is VNO. The probe is too high. Good. The focus is all right. Now I'm going to use heel lifting. Thank you. Heart shape, deep, superficial, go, 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 go. Easy for me. But if you do not remember anything after two Thai beers and forgot what I told you today, don't worry, there are some shortcuts. Remember, in the anterior knee, you know how to look at the lateral suprarachis, right? Good. Fluid, thank you. Fluid, just a little bit. Thank you. Find the rachis, then turn 90 degree. Turn 90 degree. Straight forward. Okay? Do not move, then turn 90 degree. Do not do this. Turn 90 degree. Sorry, wrong directions. Okay. Then move posteriorly. Dun, 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 dun. Dun, 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 dun. 5 seconds. Medial collateral ligament and the medial meniscus. Did you see that? Easy, right? Very easy. Very, very easy. Okay. If you want to find the pacer insurance, keep moving backwards. Dun, 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 dun. And find 2 layer structures. And using this is still medial collateral ligament. Okay, 2 layer structures. Professor Pimon Kong now is very focused. He knows the color of the medial collateral ligament changed, right? Because the alignment of the medial collateral ligament changed. So we don't need to worry. Now the brightness is pacer insurance. Dun, 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 dun. Medial collateral ligament. Dun, 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 dun. Dark, right? Pacer insurance. Dun, 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 dun. Medial collateral ligament. Dun, 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 dun. Become dark, right? Very easy, piece of cake. Very, very, very easy. And the heart shape, the triangle shape, still here, looking at you, right? As long as you find the heart shape, you just keep moving back, forwards, backwards, you get a lot of structure you need. Okay? Okay? Okay, really, you know? Okay? Okay, do it for me. Come on. You just make a toilet. Okay, okay, that's very good. Very, very new excuses. Okay. Yeah, another way, but we don't have time to demonstrate. but you can practice if you want. Another way is we check the mobility of meniscus. Flex to 90 degree. Thank you. 90 degree. Sorry? Oh. Okay. Condyle tibia, triangle shape, beginning line. Okay. Then, thank you. We check the mobility of medial meniscus. Is there any tear or dislocation? When we check the mobility of the medial meniscus, we use external rotations. No? Good. If there is a separation of the triangle shape, that means the tear of the outer ring of the medial meniscus or dislocation. If there is a cyst, in here, that also an indication of meniscal tear. Okay, and the cyst will help you to identify the dislocation of the medial meniscus. Now, we are going to next step of our presentations. Lateral knee. So, can you sit in here and face to the screen? Yes. You see here, and face there. Yeah. Thank you. So they can see my probe. Yes. Thank you. Usually, I sit here. Okay, but if I sit here, most of you cannot see how to look at how I probe my. I put my probe. Can you hold for me? Thank you. Okay. This one is okay. Find the fibula head by palpation. Find the lateral condyle by palpation. This is the lateral collateral ligament. Okay. The tendon. Yeah. The tendon below the LCL is popliteal tendon. Popliteus tendon, LCL, Okay? Triangle shape. Lateral meniscus. Bicep femoris tendon. Okay? There's a small ligament in here. If we cannot find it, it's okay. It's okay. So we are going to look at LCL, popliteal tendon, bicep femoris, one, and then the lateral meniscus, 4 structures. They are very, very easy. Very, very easy. Find the popliteal. Find the popliteal sulcus. Okay. So if I ask you to do the LCL, and I will say, please, right? Can you find the LCL for me? Please. Please, popliteal sulcus. Remember that? When I say, can you find the LCL for me? Please. Popliteal sulcus. Please. PS. Popliteal sulcus. Find the focus. Yeah. Right? Good. Everything start from popliteal sulcus. Please. Then find the fibular head. Okay? Then you are no trouble to find the lateral meniscus. Then move upward. You find the bicep femoris tendons. Okay? Then, I don't know, in Korea, 50 people do not have fibula. Yeah. Europe, 15 to 20 people. Yeah. I don't know in Taiwan because I have a fibula. I practice very quickly because I use myself. But 2 of my students, they don't have fibula. No. So, okay. Yeah, oh, thank you. Right. So, find the lateral condyle. Find the fibular head. Good. So, see? 2 seconds job. Freeze. Popliteal sulcus, please. LCL. The structures above, please. First one, popliteal tendons. Second one, dark tendon, popliteus tendon, because it is curved. It is curved, dark. LCL, relatively straight, bright. Capsule. So, see, it's very easy. 2 seconds job, as long as you find the please. Okay. When I was young, this name, this is not popliteus sulcus. This is Lucas sulcus, because a scientist Lucas, name the suckers by his name. But people do not give a, so they use Pobritia suckers. Yeah. When I talk to my student by Lucas suckers, they cannot find any information in Google. So they tell me, Professor, there is no suckers named like Lucas suckers. And I check my note. Yes, it is. It was Lucas suckers, but people forget his name because they do not want to remember his name. Okay. So do you know the Schlatter disease, right? Schlatter disease. Okay. All right. Defreeze. Okay. Find the two-leg structures. Now I'm using deeper depths, but I still put the range of observation within the focal zone, right? So that give me a better image quality. Please press the freeze for me. Okay. Again, LCL, head of the LCL, focal zone. Okay. As I said, this machine is very good about the range. Yeah, about the range between 1 and 2 to 3.5. Okay. Please. Yes. Okay, not now. Okay. Thank you. It's all right. It's all right. You can. Okay. LCL, popliteus, triangle shape, lateral meniscus. Okay. Because they cannot see the TV, so they give up. Okay. It's a then move upward, bicep femoris. Fibula head. Okay, this is LCL. LCL insert at head of fibula. So I need to trace. Dun, 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 dun. Head of the fibula. Okay, freeze. The fiber of LCL sprayed. The fiber of LCL sprayed. So it's dark. The trunk, the body of LCL is bright. Okay? When I was young, my teacher, who teach me sonography, at that time, LCL is dark. the standard view of LCL is dark. Why? Because of the device and the skill is not so good. But now, the LCL, standard view of the LCL is bright. So if you look at some textbook, show you LCL is dark, is probably 10 years ago, 15 years ago. Yeah. But now LCL is bright. Yes. Because we know police is very important. Cool. Then, yes, thank you. Find the LCL, find the fibula head and move forward and tilt it a little bit. This is tibia, too much. Okay. Okay, freeze. And you use heel walking to move from the LCL to bicep femoris tendons. Thank you very much. Thank you. That's the thickness of the bicep femoris tendons, very bright. Okay? So, last one, sorry. We are very interested to know you have fibula or not. In my country, it's a joke. Ladies, the beautiful lady always have fibula. I don't know, it's a joke. Because I don't know, but I think it's a. We also, do you know the supermodel? Supermodel, they often have two kind of joint disease. Fraser hallucis buckus, because of the shoes. Yeah, and another is TMJ. Yeah, they come to NTU hospital by private pathway. Yeah, because wearing high shoes and the narrow, yeah, so they're easy to get, yeah, something like that. Yeah, it's very very likely to get the Fraser hallucis longus, because the supermodel they only eat the processed food to keep their body shape. Most of the food are very soft, so they have underdeveloped TMJ joint. Yeah. And if you look at the news, the news reporter, the beautiful lady, they report the news on TV, right? If they speak, and they, sorry, I have to move my mask a little bit. If they speak like, they are easy to get TMJ joint dysfunction. Very easy. Very easy. I have several. A friend of mine, she helped me to. When I was young, she helped me to, know another girl, and she now is the wife of my best friend. I don't know why, but the best friend, he's the top expert in TMJ joint. So sometimes we discuss, and I don't want to discuss my high school life, right? Because that will show everything. So we discussed the TMJ. And he told me, a lot of supermodels have TMJ joint, and the news reporter, they have a lot of TMJ dysfunction problems. Yeah, but when we discuss who started the joke about the phi beta, and no one can remember. Okay, Pro. Can you, face down? Okay, this is okay. This is okay. Yeah, 再拉影对 Thank you very much. Oh, this is okay. Yeah, just cool. To find the bicep femoris, we move upwards, right? To find the bicep femoris tendon, we move upwards. To find the fibula, we move downwards. Yeah. Defreeze. Okay. Popliteal sulcus, right? Please, right? Then lateral condyle. Move posteriorly. Freeze. Fibula. Echoic shadow. This is cortex line of lateral condyle. There is a echoic shadow, right? From this screen is very, very, very clean, very, very clear from the screen. But thank you. This is the cortex line of the lateral condyle. This part cannot be seen, right? There is a echoic shadow, right? Echoic shadow. So this is fibula. The size